Hi, my name's Lisa Wild and I'm the Director of Research and External Affairs at Bowel Cancer UK. And I'm delighted to introduce you to Dr Kevin Monahan, who's a consultant gastroenterologist at St Mark's Hospital in London. Kevin's joining me today to answer your questions on screening, diagnostics and people at high risk of the disease. So thanks for joining me, Kevin.
Thank you.
I've straight in with the first question, which is about Lynch syndrome. My dad was diagnosed and then died of bowel cancer. My paternal grandmother had died of cancer of the womb before I was born, and my sister died of a brain tumour when she was only 12. Do you think that would signify the possibility of me having Lynch syndrome?
Thank you very much for that question. It's very common for people to have a family history of bowel cancer or other cancers because, unfortunately, cancer is a common disease. Although it does seem that in your family, there are a number of people affected with cancers that may be related to Lynch syndrome. The short answer is that if you are concerned about a family history of cancer, then you can speak to your GP, and GPs have guidelines about who they should consider referring for further investigation and assessment, which may include investigations for a condition such as Lynch syndrome. And with a family history of bowel cancer and cancer of the womb, that is a possibility, yes.
Thanks, Kevin. The next question we have is, when I was diagnosed with bowel cancer in 2016, I had no symptoms. Now, because of lockdown, my colonoscopy has been delayed for who knows how long. When will we see screening and checkups return?
We want to try and reintroduce the service that we had prior to the coronavirus pandemic as soon as possible, but we're faced with a number of challenges, although we are finally, thankfully, able to start to reintroduce some of these very important investigations, including colonoscopy. The difficulties that we have are that we want to try and keep people safe, that we don't add risk of them becoming infected, because coronavirus is a dreadful disease, and many of us were redeployed for a time, and we're not redeployed anymore. So it's not a workforce issue. We're trying to ensure that if people are coming to hospital, perhaps the same hospital where there are many people with coronavirus, that we're ensuring that they're kept safe, and we have to develop pathways, literally pathways through the hospital that mean that people aren't encountering patients with coronavirus. But it is extremely important, and we are trying to be as creative as possible to try and ensure that people can access these extremely important investigations. So we're performing endoscopy for our NHS patients in independent hospitals, which we've never done before. And with each week, as we learn from how we're able to deliver endoscopy at this very difficult time, we're stepping up what we can deliver. But it is a difficult process, but one that is extremely important to us as clinicians as we return to the work that we were doing prior to the pandemic. And hopefully we'll continue to be able to expand the provision of these important tests to people not only who've had bowel cancer, but also those who have symptoms that would suggest that they may have a cancer, or other people who are at high risk.
Kevin, that sounds incredibly challenging, but it's very heartening to hear that you and your colleagues are doing the very best to get things back to an even keel. We have a similar but slightly different question here. I have FAP, and in April I was due an operation to investigate my rectal bleeding, but it was cancelled. I'm also due a surveillance scope in September. When do you think this will happen?
I think there are a lot of people in this situation, and in a specialist service such as ours, we have an idea about who's expecting to have what test at what time, and we have arranged a prioritization for things, not only just for surgical procedures, but also for endoscopic procedures. So we know that when we can provide a surgical procedure or an endoscopic procedure, we know who needs it the most, by and large. However, part of that, it depends on communication with people who are affected. There are two things I'd advise you to do. First of all, you can speak to your GP. GP practices are open. There are also new ways that GPs are working in order to provide access to care for non-coronavirus issues, including hot hubs in the community. And secondly, if you have FAP, you may well be linked to a specialist team, such as the polyposis registry that we have at St. Mark's, or the Family Cancer Clinic. And teams like that will know who you are and what's expected, so you can get in contact with them. And there are specialist nurses and doctors, other clinicians such as me, who've returned from being redeployed to coronavirus wards and are providing that care for people with FAP and other high-risk conditions. So please get in touch.
Thank you. We have another question about Lynch syndrome here. My husband has Lynch syndrome and was receiving surveillance colonoscopies every 2 years, whilst his brother, who lives in France, gets these every year. My husband was diagnosed with stage 3 bowel cancer in 2018 when his surveillance screening had been delayed. He was told he would receive a quarterly B12 injection as the part of the bowel that makes or processes this would be removed, but he hasn't had any. He's been put on yearly screening for 3 years. My big question is, what is regarded as best practice for after cancer? What would you be happy with for your loved ones?
I think it's very important, and there are, the most important thing about care after cancer is that it's holistic. There are different goals that clinicians and people want to try and achieve after a diagnosis of cancer, but ultimately that care may be personalized to individuals depending on what kind of treatment they've had. And for example, if you're concerned about B12, sometimes it's anticipated that people might need to have a B12 replacement injection after particularly a right hemicolectomy, which is where B12 is sometimes the area of the bowel that absorbs B12 is removed, but it's not always necessary. So it may be that if the B12 level has been normal since surgery, that is actually not required. Obviously, I don't know for sure, but you can inquire from your colorectal nurse specialist or your colorectal team as to whether or not the B12 level has been checked, or indeed it's something that a GP can do as well, because they can access tests such as B12 levels. But there's more, obviously, than that. There are people will have access to CT scans and blood tests, colonoscopy, as they have regular checkups, particularly over the first 3 to 5 years after diagnosis of cancer. Some people will need psychological support. They may suffer from the consequences of the cancer therapy, which, although may be life-saving, can have implications for their health. And there is something called a holistic needs assessment that's performed usually by a colorectal specialist nurse within the colorectal team, which aims to identify specific needs in individual patients. But what I'd advise you to do is to speak to your colorectal nurse practitioner, who may have been redeployed previously, earlier in the pandemic, but is more likely to be available now. And you also have your GP who can help you and help you identify how you can access appropriate care at this time and in the long term as well.
Great, thank you. We have a question here about symptoms. I have had blood in my stool, which is slightly slimy for the last couple of days, and a dull ache in my stomach. I have a yearly colonoscopy at St. Mark's every September, as my brother has had bowel cancer and we both have serrated polyposis syndrome. What should I do?
So you may be known to me, I don't know who you are, but let me say to you, I would always advise people who are, whether they're known to a specialist service or not, who have blood in the stool, especially those who are at high risk, that they should seek an urgent appointment with their GP. And if you are known to a specialist service like ours, then we're here for you. You can get in contact with us and we can escalate your investigations to prioritize investigations for you based on those symptoms.
That's brilliant, Kevin. It's so important. It's something we say as a charity. If you have any symptoms, get them checked out. People will absolutely want to see you. So our sixth question is, in January, I had the right side of my colon removed. The question I have is, some days my stools are somewhat normal, and other days I feel like whatever I eat just goes through me. Are there certain foods I should avoid?
This is an important question, and it's something that we see in people, whatever kind of surgery they have in the large bowel, they will have a change to their pre-surgical bowel habit. Specifically, if you've had a right hemicolectomy where the right side of the bowel is removed, there are bile salts that you would often absorb at the end of the small bowel, and this part of the bowel is often removed at the time of that operation. Bile salts are a laxative. Therefore, if you have this part of your bowel removed, it's not unusual that you will have episodic or persistent loose bowel motions, and it's easily treated. There is a medication that binds bile salts, and it's widely available. And I would advise you just discuss this with your nurse practitioner or with your GP. And with regard to your diet, so the main function of the large bowel is to absorb water rather than nutrients. And you still have quite a lot of large bowel left, so you shouldn't have diarrhea because of your diet. Nevertheless, some people may benefit from a lower fibre diet after such an operation, because fibre is also a laxative and may stimulate the bowels. So it may be worthwhile seeking advice about the dietary management, your dietary management after you've had such an operation. And once again, I would say the colorectal nurse specialist is probably the best person to advise you about this.
Thank you, Kevin. And our final question is about bowel screening. What should people do if they've been told they have a positive result after completing the bowel screening tests they've got through the post, but they're still waiting for a colonoscopy to investigate further?
This is extremely important, and we're aware of this issue. And we have prioritised people such as those who've had a positive stool test and weren't able to access a colonoscopy afterwards, because we recognise that their risk of having bowel cancer is considerable. And in fact, because we can measure different levels of abnormality in the stool test, the National Screening Services are designing a method of identifying the very highest risk patients in order for them to be able to access colonoscopy soonest. But also, all people who have had an abnormal stool test will be at the top of the list when services are opening up again, as they are over the next few weeks.
Well, thank you so much for your time today, Kevin. It was a really useful discussion, and we're so grateful to have your expertise and insight to answer the questions that matter most to our community right now. If you'd like the most up-to-date information and guidance regarding coronavirus and bowel cancer, you can visit the dedicated section that we have on our website at bowelcanceruk.org.uk/coronavirus.